Hello, I am Demetria McNeil, Assistant Professor of Medicine, Division of General Internal Medicine, University of Colorado, and Shoots Medical Campus. And I will be discussing disparities in care, detection of PAD, and emerging treatment options for chronic PAD. PAD affects different racial and ethnic groups disproportionately, and understanding the risk of each population is important in terms of tailoring targeted intervention. We know that Black Americans are more likely to have PAD than any other racial or ethnic group, and also tend to present with more severe disease, have more atypical symptoms, and are more likely to suffer worse outcomes. Therefore, I will focus on the effects of PAD on Black Americans for the next few minutes. Recent data by Chen and colleagues explored the racial and ethnic disparities in PAD-related hospitalizations. Regression analyses adjusted for age, gender, CCI, primary payer, patient location, bed size of the admission hospital, geographic region of the hospital, and rural and urban location of the hospital. Black Americans had higher odds of amputations. These findings are analogous to prior research. Another study evaluated the impact of race and SES on amputation risk in PAD patients. The exposures were race and SES. The outcome was incident major amputation. Black Americans were significantly more likely to live in low SES neighborhoods and to present with advanced PAD. Black American patients had a higher amputation risk in each SES stratum compared with white patients. We know that health disparities exist, so it might make sense to reflect on how we got here. This is an opportunity to understand the complex and intertwined nature of race, particularly the Black American race, and health outcomes. Hackler, Hamburg, and Solaru conducted a review to highlight healthcare inequities. What is particularly enlightening about this project is the depiction of how structural racism leads to disparities in PAD outcome for Black Americans. Appropriately, it starts with slavery and ushers through post-emancipation and the Jim Crow era. When you think about it, there's a part of this equation that we cannot do anything about. However, there is a part that we can do something about, as noted in red. These are issues specifically around social determinants of health, which greatly impact PAD outcomes. These are the areas we can focus on in clinic. We know that there is a three-pronged approach to PAD management: reduce cardiovascular risk, alleviate lower extremity symptoms of pain while improving quality of life and maintaining functional status, and ultimately prevent limb events and limb loss. When considering the well-known traditional options, I encourage you to align what you know with what you practice. For example, hypertension treatment is the lowest among Black Americans, despite the fact that the rates of hypertension prevalence are highest in Black Americans, further exacerbating this already exhausting issue. Equally, Black Americans have lower scores for objective functional measures and are less likely to participate in exercise. Therefore, it's extremely important that Black Americans with PAD are encouraged to participate in exercise therapy. Recently, Ndandu presented a case of a 61-year-old Black female patient with PAD that initially presented with a left third toe wound. The wound continued to worsen over time. Below the knee amputation was discussed with the patient. The option of DVA was considered as a last option before amputation. After the procedure, the wound healed and the limb was salvaged. Oftentimes, because Black Americans present with greater severity of disease, amputation is considered an option and usually a first option. But there's another procedure, DVA, that is considered a last option before amputation. I encourage you to consider that. Recently, the AHA released a policy statement to reduce non-traumatic lower extremity amputations by 20% by 2030. A number of evidence-based diagnostic and therapeutic approaches to PAD can reduce amputation risk. However, their implementation and adherence are suboptimal. To stop and indeed reverse the increasing trends of amputation, actionable policies that will reduce the incidence of critical limb ischemia and enhance delivery of optimal care are needed. Adoption of quality measures for PAD care, affordable prevention, diagnosis, and management, regulation of tobacco products, clinical decision support for PAD care, professional education, and dedicated funding opportunities to support PAD research are necessary. This effort will require intentional partnerships with stakeholders outside of the clinic, hospital, and campus in which you work. So I encourage you, get out of the building and let's improve PAD outcomes. Thank you for your time.